comes, let's talk about Morton's neuromas. Dr. Morton put his name to this a long time ago. And when I say a long time ago, I'm thinking it was about 100 years ago. Morton's neuroma, typically a patient will present with pain, burning, numbness, pins and needles, tingling, usually in two toes, usually, and underline usually, toes 3 and 4. Neuromas can occur in any interspace, meaning the space between the first and second metatarsal, second, third, third and fourth and fifth. Most common, Dr. Morton described it in the third metatarsal interspace. And again, the diagram, you can see the arrow, the marker saying Morton's neuroma. So the pain is usually on the ball of the foot, not as much on the top of the foot. Sudden onset, the patients will say, I was walking, I was fine, all of a sudden I just felt like I stepped on something and the pain was so intense, I had to stop. I took my shoe off, I rubbed my foot and the pain went away. And put my shoe back on and started my walk again. Sometimes can finish the walk, sometimes cannot because of the intensity of the pain. Not caused by any injuries, usually. We don't know why they form. Sometimes when we take an x-ray, the two metatarsals, let's say 3 and 4, where the neuroma is between, will look close together on x-ray. So you can imagine if there's a little nerve sitting between those two metatarsals and they're close together, those metatarsals can rub against each other and the little nerve tissue that's caught between the metatarsals gets irritated and enlarged. So basically it's a thickening, not really a tumor, even though the word neuroma, if you break it down into neuro meaning nerve and oma meaning tumor of, it's not really a tumor per se, it's a thickening, it's a fibrosis, it's an enlargement of the nerve tissue. Usually sudden onset can be minimal at first, and at times it can be to the point that you cannot do any type of walking because of the pain. See this little picture of a metatarsal pad, and that's that tan material shaped like a rounded triangle. Simple, but very, very effective in reducing the pain. A lot of the medical supply stores do have them now. Podiatrists recommend them a lot. I think if you go into a medical supply store and say, I'm looking for a metatarsal pad, salespeople will know exactly what you're talking about. Now, the pad doesn't go where you think it should go. The pad, if you look at the picture on the right where the circle is, that's where the neuroma is. The pad does not go there. The pad goes behind where the red circle is. So the idea is when you step down, your weight is on the pad and not on the neuroma. Flip that picture of the metatarsal pad around 180 degrees. So the wide part of the pad goes towards the toes. The narrow part of the pad goes back towards the heel in that direction. And please make sure that the pad is behind where the neuroma is. You usually can tell, you feel the ball of your foot, the metatarsal, the ends of the metatarsals, and just drop back behind it. You better to err in the backwards instead of forwards. If you go too far forwards towards the toes, you actually may make the neuroma hurt more. So very helpful. Metatarsal pads are extremely helpful. The other thing we will do, now we'll take an x-ray to evaluate the position of the metatarsals. Another reason for x-rays is to make sure that there's not what we call metatarsal stress fracture that can sometimes occur, a slow fracturing of the metatarsal bones. Again, in somebody who has not been exercising and then starts an exercise program, sometimes that stress of the activity can cause a metatarsal stress fracture. So we want to make sure we're making the correct diagnosis. If we rule out metatarsal stress fracture, then pretty certain that we have a neuroma. Good quality MRI can sometimes pick up a neuroma. Clinical examination is probably the best way of making a diagnosis. There's a certain examination, certain maneuver that we do in terms of squeezing the foot and pushing on the bottom at the same time, and we can get this, what's called a click, and we can feel the click, the patient can feel the click, and that usually is indicative of a neuroma. Best treatment, honestly, is the cortisone injection from the top of the foot between the metatarsals, depositing a little steroid around the neuroma, and again, 2 or sometimes 3 injections spaced out over 3 weeks apart will eliminate the pain, and follow up with the metatarsal pad. Most important, avoid shoes with a tight toe box. So the dress shoes with the pointy toes will compress the metatarsals, will irritate the neuroma. The shoes with the high heels will put obviously more pressure on the ball of the foot and will also aggravate a neuroma. So let's get into a flatter type of shoe with a wide toe box. That will eliminate the compression of the nerve. Steroid injections are very helpful when all else fails. Outpatient surgery is performed to remove the enlarged nerve tissue. It's a relatively, I'll use that word, I'll stress the word relatively, but relatively simple surgery and recovery time. With any surgery, the caveat is there's no guarantees, and things happen. But the incision, it's an outpatient procedure. The patient is usually just sedated, like with a colonoscopy, and local anesthesia is infiltrated while the patient is sedated. Small incision is made on the top of the foot between the metatarsals, and dissection is carried down. You find the neuroma, you dissect it out, and you cut it, and you now have removed the neuroma. And after 3 to 4 weeks of healing, and you're ambulatory while healing, most patients are back to what they want to do. The biggest caveat I give patients with neuroma surgery is on occasion, not that common, but on occasion, one can develop what we call a stump, S-T-U-M-P, a stump neuroma. So where the nerve was cut, the body, for whatever reason, decides to form a new neuroma where the nerve is cut. Now, if it's identified early enough, a couple steroid injections usually resolve it. On a rare occasion, we have to go back in and find the stump neuroma and dissect that out.